Welcome to This Just In, the show bringing you the latest advancements in healthcare, strategy, innovation, and public policy. And now, for the fastest voice in healthcare, here's your host, Justin Barnes.
Welcome back to This Just In Radio Show, broadcasting live from Health 2025 in sunny Las Vegas. I'm very excited to introduce my next guest and new friend of the show, Dr. Nainesh Parikh, Vice President, Chief Clinical Expansion and Partnerships Officer at Moffitt Cancer Center. Welcome to the show, my good friend.
Thank you, sir. Thanks for having me.
First of all, we were connected by our good friend, Vincent Frakes. Yesterday, he proactively connected us via text after you had a great talk at Decimal Health's
Innovation
Forum.
Summit.
Yeah, Summit yesterday morning. First of all, great job there. Before we dive in, tell us a bit about your background. You're new to the show, so you're a new voice to the show.
Sure.
Tell us about your background a little bit.
Sure. Well, thank you again for having me. Really an honor to be here. Thanks for the feedback yesterday.
You got it.
So I'm an interventional radiologist. I focus on prostate cancer, and I focus on something called prostatic artery embolization for men with enlarged prostates, and specifically prior to definitive therapy. Obviously, I'm deep into the prostate cancer landscape. I spend half my time doing that. And then I spend the other half of my time as the Vice President, Chief Clinical Expansion and Partnership Officer. Doing that, I focus on Moffitt's growth outside of our main area, so around Florida, around the region, internationally.
Yep.
And then I think about ways that we can bring our care closer to patients and ways that patients can access our care when they need us. And even when they don't, how can we make sure that we're taking care of our patients? That's kind of the general overview. And then before that, I used to be the Assistant Chief Medical Officer with a focus in finance strategy and digital innovation. So that's kind of how it all...
At Moffitt?
Yep.
Okay. How long have you been at Moffitt?
10 years. Coming up this summer, it'll be 10 years.
Very cool. No, that's awesome. Jess Frakes also, Fralick initially, but Frakes now.
Jess is really close. Jess and Vince are both really close friends of mine. I love them both. Shout out to both of them.
Yes, big time. So diving into some of the questions, then we're going to talk about curing cancer. So we're going to absolutely debate that.
All right, let's go.
But before we get there, what progress are you most excited about seeing in the industry today?
Let me ask you, clarify a little bit. Do you mean in terms of digitally enabled technology and tools, or do you mean just generally speaking?
What excites you? Like, so when you think about, for me, I've worked on interoperability for now 20 plus years, and so it's really cool to see we have a long way to go. We've also made tangible strides in interoperability. So that's one of the biggest ones for me personally, to see. So what do you get you excited about?
What given that we're here at HLTH, what excites me is the opportunity, and everybody talks about AI. But I actually think what excites me is the opportunity for physicians to be supercharged by language models, not just AI, not just agentic AI, but how do we allow ourselves to be more creative in delivering care and kind of don't sweat the small stuff.
Right.
And to me, everybody's trying to search for this. Someone that I was talking to yesterday told me, if you thought about EHRs like 25 years ago, there was like 1,500, and now there's 3, right? Or maybe 5. Maybe there's only 2, depending on who you ask. But
I helped start one of them, so
exactly. So I think that it's exciting times because maybe some companies will lose, but a lot will win, and the ones that do, I think, are really going to supercharge how we practice medicine, and that's really what excites me.
Yeah, and I think one thing I heard yesterday, actually, it might have been on. It was actually on the Decimal Health at the Summit. How someone today, this is a little bit off topic, but something to keep an eye on, certainly if you run a health system, they might have 15 different AI models, or they might have 5 today, they might have 7 next year, then maybe 15 a couple years after that. All different governance models possibly, and there's a lot there. That's something people need to keep an eye on. I actually had one of our really good friends that from last night on the show earlier today, and I asked him, and obviously everybody needs an individual strategy based on their health system, but you want to think about this at a global scale or a holistic scale for your organization, because there's a lot to manage there.
Well, what's hard about it though is that so much is changing so quickly, and there's so much unknown. How do you put governance structure around something you just don't know?
Right.
It's like trying to drive a car without ever having driven a car. Right. You just don't know what you don't know. So I totally agree with you, and I actually think what's less important, and I think we're finding this at Moffitt, what's less important is the structure of the governance, and what's more important is that we're all on the same page and we're all talking about it.
Right.
Because I think that understanding how AI is going to come, and just being open-minded to the fact that it's really rapidly changing what's normally a slow-moving beast like a healthcare system is helpful for everybody to say, nope, let's continue to think creatively about how we deploy AI and really how it marries all the other technological applications throughout the institution.
Yep. And one thing I did about a year ago, I helped on the CHI early group when CHI, the Coalition for Health AI, came together. I joined one of their work groups just to make sure, we do the education, because again, it goes back to this is just all new, so we want to put all of us who have some experience together to begin to share some of those best practices out with people. So I think we got to continue to educate, and I totally agree with you, getting on the same page there, and also starting off somewhat small in some ways too, to understand what problem you're truly trying to solve, and so that critically important for health systems as a starting point. But that's another conversation for another day, because there's a whole lot there. But what trends are you seeing in healthcare or digital health also that you want to bring up?
Biggest trend, I touched on it yesterday, is budget, and it's not a fun topic,
right?
And it's not like a great one, but
I appreciate what you said. So actually, do talk about that, because that's significant.
So I feel that most health systems, most people, right, in the world are just suffering from rising costs, and everybody's managing a tight budget. Obviously we all know you can't just pull the lever of passing through costs to the consumer,
Absolutely.
right? The insurance companies don't work that way.
Right.
So when your cost goes up, whether it's wage inflation, if it's cost of, hard assets, cost of capital, cost of disposables, when those things go up, how do you adjust? And right now, all of those things have been going up, especially in the post-COVID era. How does the health institution adjust? And then the second thing is, there's so much at our disposal. There's so much that is being offered to us. Yeah. When you're managing the budget, how do you sift through the entire universe of offerings and say, no, this is the one that I need? Because for any given problem, 100 solutions,
right?
And then never mind the ones that you go out and solicit. There's 500 people coming at you, every day saying, let's offer this, let's offer that. How do you sift through the noise while managing a tight budget? Right. That, I think, is the hardest trend that we're all facing. And everybody I talk to, especially our CancerX partners, everybody's feeling that same thing.
So how do you navigate that as a healthcare organization or a leader? How do you navigate that?
Yeah, I smile because I think that some people, and I actually don't think this is bad, some people might say, just put your head in the sand. Put your head in the sand for 6 months or a year and just say no. Yeah. And to be honest, it's actually not a bad way to do it. We've had some really constructive conversation at our institutional level. And the truth of the matter is, we've just kind of put a pause on a lot of things. We put a pause just to catch our breath, right? Even putting like a 3 or a 6 month pause, right? And saying, listen, we're not going to hire, we're not going to deploy new apps. What about this is really going to be patient necessary? Right. Regulatory and safety, sure, that's but very few of those things happen over a 3 or 6 month process. Right. So I think that's one way to navigate it. The second way to navigate it, I think that goes along with the first point, is you've really got to be mission critical. And what I mean by that is, whatever your strategy is and whatever your mission statement is, you've got to make sure that whatever are your solutions align with those strategies, because there are 10 great solutions for every problem out there. For example, if we talk about some of the ambient listening and some of the AI, that we were talking about yesterday, the Sukis, the Abridges, all fantastic people, fantastic teams, great software. But very specifically, as opposed to maybe our partners across, major organizations like Advocate Health, for us, we're really focused on oncology, and not just on oncology. Within that, super duper specialization. Not better, not worse, right? Just different. Yep. And that's specific to our mission statement. So, you've got to really fine tune your lens when you're looking at some of these solutions. And I think putting those together, you could just say no to manage the budget. Yep. And then if you are going to allow any capital or any dollars to be at work, making sure that ROI is actually third on the list. Yep.
Great advice, brother. So thinking beyond today, because I also want to spend a couple seconds talking about curing cancer, because we absolutely can. Thinking beyond today.
Wait. For those that didn't know about this, him and I, yesterday at a reception started this debate. And I kind of stopped him in his tracks. He was like, no, we're going to cure cancer. And I was like, no chance. And he's like, wait, what? And he's like, how can you say that? And I was like, let's save it for tomorrow.
Yeah, we'll get to that. Because Kamal was before you here, so we've already talked a little bit. Sure. But we have a good foundation to work from. And then I am going to devote some resources. My radio show and some other investment stuff. I'm going to create a total track over the next couple of months, if not 6 months, on just this one topic. All right. Because also I'm close to the CancerX people, and so I didn't realize all that. It kind of all came together last night.
Right, which is
so this is going to be fun.
Yeah. Let's do it. I'm excited.
Yeah. So, but before we dive into that, and we will cure cancer, we will But think about beyond today. What do you see as a key strategy or trend that we must be ready to successfully navigate in 2 to 3 years from now that we're not talking about, we haven't seen here at Health?
Yeah, I think we need to use our digital tools, and I struggle to just say AI. I think it's every tool in the digital toolbox to supercharge clinical trial research.
Okay.
And I don't mean clinical trial matching. What I mean is, how do you figure out doses and regimens that will materially impact and save patients' lives? And I don't even mean with existing therapies. I mean, how do you write models where you can test new proteins that maybe haven't even been generated yet and save the entire process time from going from, the lab to a molecule to, safety studies? How do you actually write accurate enough models that can go through and say, you know what, this combination, it's like trying on clothes, right?
Right.
You can put them out on your bed and you can say, oh, that looks good or that doesn't look good. Or better yet, with computer software, you can create a mannequin and just put a shirt on and put pants on, and you can say, no, that doesn't look good. No, that looks great, right? How do we do that? I think for therapeutics, and I think there are people doing some of that work. But to me, that's the trend that we're not talking about right now, at least not here.
It's excellent, great point, and certainly with the amount of data that we're going to be collecting with AI, you layer over that. Oh my gosh,
correct,
absolutely right. So now in our closing minute. Just to whet the appetite of everybody. Let's talk cancer. Better yet, let's talk curable cancers.
Got it.
And our debate last night was, I said, there's enough data, because I've been doing interoperability data for a long time, actually built the whole research vertical at my last company. But we always said, in America, there's enough data siloed to cure cancer. I think it's just been, we always just joked about that. And I said boldly last night, there's enough data just in Florida, because we all live in Florida, to cure cancer. And you said, absolutely not. And I said, there absolutely is. And then we kind of qualified it a little bit deeper and said, maybe not cure all cancers because we don't know enough about some of that. However, what was really cool and what got me really excited is maybe up to 70% of cancers we could at least treat as a chronic condition and maybe give quote unquote cures for maybe up to 70%, which is, I've never heard those. That's exciting. We need to be talking about that kind of stuff.
Right.
So the floor is yours, my friend.
Yes. So, and we'll do it in the closing minutes. I'll be cognizant of time. So, number one, the reason I was saying we definitely don't have the data is because so few people get cancers and are treated in a uniform way that you just data-wise, it's very hard to use that data to inform future therapy.
Very fair.
Okay. The second, and it's always so disparate across cities, across states, across providers, and it's not just the provider's fault. Patients are going through the journey, right? So what they received last week, their whole protoplasm now changes week to week. Second thing, curable cancers like prostate cancer and breast cancer, as long as we can actually get them early, I think we can definitely cure. And the earlier we catch them, the more chronic of a disease they can likely become. What's exciting to me is how, for example, at Moffitt, we have a whole adaptive therapy group. We are starting not to just give the same dose. We're starting to adapt all of our doses based on what we think the cancer is doing on imaging and on blood testing. That, I think, is a game changer and will allow patients, because they always say, time on chemo is more important than, or time on systemic therapy is more important than the actual strength of the systemic therapy. And for as long as patients can tolerate the treatment, they'll do better. And the last thing I'll say is, I actually think it's not just the quote unquote curable cancers. I think it's like, pancreatic cancer and GBM, two of the worst ones, especially metastatic or stage 3 or 4. I think making disruptive changes, because we really have nothing great right now, that's where we'll start to see, okay, instead of an overall survival, 5-year survival of like less than 10%, we can start moving that needle to greater than 50% when we start unlocking the right scientific theories.
Okay. Nainesh, you get the last word on that, and we're going to follow up on this soon.
Let's do it.
Thank you, brother.
For having
me. Thank you. Always.